Hello, overcomers, and welcome to this special episode of Connect Ovar Coffee. This is Ovarian Cancer Awareness Month, and we are so excited to welcome you to this milestone episode and a very special episode with our special guest, Dr. Alejandro Rauh-Hain. So, Dr. Rauh-Hain is a gynecologic oncologist at MD Anderson Cancer Center. His interests include the surgical treatment of gynecologic malignancies and the management of rare gynecologic tumors. He's also interested in research studies conducted in real-world clinical settings to reduce disparities in gynecologic cancer and improve care of young women with cancer. Dr. Rauh-Hain is also involved in a few landmark initiatives aimed at signifying the role of genetic testing in ovarian cancer. So we have a lot to chat with him today, focusing on not only understanding the disease, as well as also, learning more about the advances happening in ovarian cancer. So grab your favorite beverage and join us, and I have mine, and join us for this thought-provoking discussion. And please share far and wide with anyone who may benefit from all this wisdom he's about to share with us. So with that, a huge welcome to you, or welcome back to you, Dr. Rauh-Hain, to this episode of Connect Ovar Coffee. Always an honor to have you with us.
Thank you so much.
So, this being the Ovarian Cancer Awareness Month, it's upon us, as you know, and that we promote the 5 key symptoms of ovarian cancer via our Beach campaign. So today I want to go a little bit in depth with you in terms of each symptoms. So, and I've listed the symptoms out for you and, for others to see, as B as in the bloating, and E is the early satiety or feeling full quickly. A would be the abdominal and the pelvic pain. C would be the changes in bowel and bladder habits. And H would be the heightened fatigue, like the tiredness that we feel all the time. So talk to us in a little more detail about each of the symptoms and what should our overcomers know about this.
Yeah, so I think what I would say the most important thing is that the majority of the patients that we see with ovarian cancer really express that in the last 3 to 6 months, they have experienced some of these symptoms. And, bloating, changing bowel habits, also, feeling full earlier than they were used to. So I think those are early warning signs. It doesn't mean that if you're experiencing those symptoms that you have ovarian cancer. They are very non-specific, but those are warning signs. So if you or a family member, especially women who are postmenopausal, are experiencing those symptoms, the most important thing is to go to your primary care physician or OBGYN and just mention that you have noticed those changes so they can do the proper workup. And the workup can be as simple as just doing an ultrasound to make sure that everything is fine. But the vast majority of the patients that I see that come to us have advanced stage disease. And I would say that it would be most of them would have mentioned that they had experienced some of the symptoms, like, at some point in the last 6 months. So if you experience those, I think it's important just to have, a workup and make sure that everything's fine.
So one question I did have, though, that, oftentimes our overcomers will tell us that they obviously, not everyone has all of these symptoms together, right? So, yep. So especially, let's say bloating, right? That's a very generic experience for a woman of any age, right? Yep. Given the time of the month or other, what you ate, some simple things like that. So that's one of the key symptoms, the bloating that we call it. And so, but most of us tend to ignore it because it doesn't sound anything alarming or, triggering. So is the bloating for ovarian cancer a little bit different from the kind of bloating you would get from just like spicy food or just the time of the month? Or talk to us a little bit about that, because there are there subtle symptoms that we are missing, or is it just the persistence of it that we need to be watchful for?
So everyone's a little bit different. So there are women that might experience more bloating than others. So I think it's hard to point to one particular thing. What I would say is that if you notice two things, if it's persistent, that would be something worrisome, or if it's something new to you.
Yeah.
Like, for example, you have never experienced bloating and suddenly you're experiencing more bloating than usual. I think to me, those would be like warning signs. And again, it doesn't mean that you have ovarian cancer if you're experiencing that, but should be a red flag for you to touch base with your primary care physician or OBGYN about a workup. But those two things, like if it's new, you don't routinely experience it, or if it's persistent.
Persistent is a very important point. So for all of these symptoms, I'm assuming, like, because each of the symptoms on their own
Yep.
is pretty vague, it's non-specific, as you said. So, but in terms of persistence, then what is the time window that we are looking at? Like, should we be calling our doctors at like 2.5 weeks, 3 weeks, 4 weeks? What is it that you think? I mean, of course, every woman is different, and like you said, this is hard to just describe like that, but generally from your experience, this persistence is for how
I
long?
would say if you experience bloating persistently for 2 weeks, I think that would be enough for me to start thinking about calling a primary care physician or OBGYN.
Okay, thank you. So again, this is Ovarian Cancer Awareness Month. So in bringing hope to our teal community, can you tell us about some of the promising advances that are happening in the field for ovarian cancer in terms of, the different subtypes of ovarian cancer?
So I think in the last 10 years, we have kind of like, we have realized that ovarian cancer is like, there are different types of ovarian cancers. We used to clump particular epithelial ovarian cancers are the most common type. We used to clump them all together. We used to include them all like in the same clinical trials, treat them the same way. But through many investigations and research, we have come to realize that each of these different, what we call histologies within the epithelial type, so these different subfamilies of ovarian cancer are very different between each other. So I think that by itself has been a huge advancement.
Mhm.
We usually talk about high-grade serous ovarian cancer as the most common, but there's the low-grade ovarian cancer. And again, in the past, we used to treat them differently, but now we understand that low-grade ovarian cancer is a very different disease that, for example, doesn't usually respond well to chemotherapy. And we try to use different other therapies for low-grade ovarian cancer these days compared to high-grade ovarian cancer. There's another histology like clear cell ovarian cancer that also doesn't respond that well to chemotherapy, and that has a different molecular makeup. So we are trying to investigate what are the best therapies for these less common histologies, because we know that traditional chemotherapy usually doesn't work as well as with high-grade serous ovarian cancer. So I think that by itself has been a huge milestone in the management of ovarian cancer. I would say that the other big milestone in the last 5 years is understanding how we can implement PARP inhibitors in ovarian cancer, especially for patients that are BRCA positive or what we call homologous recombination deficient. I would say that if you look at the most recent studies of PARP inhibitors in the front line, there is a potential that we are curing patients now with ovarian cancer that in the past we would not be able to do with traditional chemotherapy. So PARP inhibitors definitely have changed completely the landscape, and we are trying to understand how we can improve, or how can we improve one, like, or avoid PARP resistance, because there are some patients that develop resistance to these PARP inhibitors. So understanding why that happens, and also understanding why some patients do not benefit from PARP inhibitors. So whether we can do combination with other therapies or other mechanisms, so we can make sure that all patients benefit from PARP inhibitors, because they are really, really powerful therapies that we have for patients with ovarian cancer. And lastly, we always talk about with patients with ovarian cancer that unfortunately ovarian cancer most of the times comes back. Although we're trying to avoid that, and PARP inhibitors is a prime example of that. But unfortunately, most of the times the cancer comes back and eventually becomes what we call platinum resistant, meaning that the platinum-based chemotherapy doesn't work as well. And in the past, we didn't have that many options, therapeutic options for patients that have developed platinum-resistant disease. But there are more and more therapies that are coming out for the management of platinum-resistant ovarian cancer. Some patients that might be watching this might be aware of Elhere or mirvetuximab, and that it really has changed again the landscape in platinum-resistant disease with very high response rates with that particular therapy, and there are more and more therapies in that space coming out, and there's a lot of research in that area. So I think those are a couple of things that I can think of that have appeared in the last couple of years.
Wonderful. So in terms of, this is also the perfect month to talk about the role of genetic testing, right? So tell us, I mean, we overarchingly, we understand why genetic testing is important, but just to go into a little more detail, tell us why genetic testing is important and why even to this day, there are many providers who do not offer it to patients, and what needs to change in that. Talk to us a little more about that.
Yeah, such a good question. So genetic testing is important because around 20% of patients with ovarian cancer are going to have a mutation, either most likely BRCA, but there are other mutations that are associated with ovarian cancer, and even Lynch syndrome might be associated with ovarian cancer. So it's important for the patient. There are two sides of it. One is it's important for the patient to know if they have a BRCA mutation, because we know that PARP inhibitors work much better in that population. So if you are tested and you are BRCA positive, you are a very good candidate for a PARP inhibitor, and we've seen that in that specific population, the outcomes are remarkable. There's a study called Solo-1 in which one particular PARP inhibitor, olaparib, there were many patients, more than 60% of the patients were alive at 7 years. And that is something that, again, we had never seen before. So very, very impressive results with olaparib or Lynparza in BRCA. So for the patient, it's important because they might be candidates for PARP inhibitors. And also, there are more and more trials that are targeting patients with BRCA mutations. So that's one thing, one aspect for the patient is important to know. And then the other part is that if you have one of these mutations, and let's say it's BRCA or Lynch syndrome, that means that your family members, your first degree and even second degree family members have a 50% chance of having the same mutation.
Yeah.
So very high rates of having the same mutation if there's a BRCA proband in the family. And if the family members get tested and they turn out to be positive as well, we have a lot of different options to try to reduce the risk of developing cancer. We have screening strategies for breast cancer. We have some screening strategies for ovarian cancer that are not as effective as breast cancer, but we can prevent ovarian cancer for those patients that have completed childbearing, that they don't want to have more kids. Removal of the ovaries and the fallopian tubes is very effective, as you can imagine, to try to prevent ovarian cancer. So there's a lot of strategies that we can implement for patients that have these mutations that have not developed either breast or ovarian cancer or even other cancers.
Thank you. So while we're on the topic of genetic testing, you did mention that there are so many genes that have been identified, right? It's not just the BRCAs anymore. So tell us about the main other kinds of genes other than the BRCA1 and 2, and that have been identified as having a role in the diagnosis and the progression of ovarian cancer.
So by far, BRCA1 and 2 are the most common.
Yeah.
But there are other genes like RAD51, BRIB, that are also associated with ovarian cancer. And probably eventually we're gonna find more and more of these kind of mutations. But those are usually not autosomic dominant, so meaning that they are inherited like to 50% of the family members, just like BRCA1. The other big one is Lynch syndrome, and I mentioned Lynch syndrome a couple of times. Lynch syndrome is associated with colon cancer and endometrial cancer, but patients with Lynch syndrome might have a risk of developing ovarian cancer up to 10% of the times. And it depends on what specific mutation the risk goes up and down, but that's something just to take into account, because most of the times people think about Lynch syndrome to colon cancer and endometrial cancer, but it is associated with ovarian cancer as well. But I would say that for the general population, BRCA is the most important one.
Okay. And so in terms of, the information about the genes being utilized to design clinical trials, and novel therapies for ovarian cancer, how does that work in terms of from the clinical aspect, that how do you use that information from the gene to design clinical trials for our overcomers?
Yeah, so right now for any trial that we have, like especially in the front line, like it's very important to know if a patient has a BRCA mutation or it's homologous recombination deficient, because if you have that, standard of care right now is a PARP inhibitor.
Yeah.
I think there's no doubt that at this point, PARP inhibitors should be the standard of care. So, if a trial is designed, it has to take that into account. What's going to happen? So right now, I would say that the biggest unmet need in the front line is what we can offer as maintenance therapy for patients that are BRCA negative and homologous recombination deficient negative.
Yeah.
Because like right now, again, and I keep saying this, PARP inhibitors, I think very well established. The data is very compelling. There are among those that are positive for BRCA or homologous recombination deficient. The data among those that are BRCA negative and HRD negative is not that strong. I think it's still, there's one particular niraparib that it's approved for those that are negative, but I think it's still controversial in the field whether how much benefit there is. I think there are some patients that are negative that are still benefit from PARP inhibitors, but it's very hard to know at this point identify those patients. So I think there are two things that I'm talking about. It is like developing clinical trials for those that are negative, or coming up with better biomarkers to really understand who are the patients that might benefit the most for PARP inhibitors or similar therapies that work in that pathway. So I think we're eventually get better biomarkers, and we're gonna be smarter about how to choose what are the best patients for these maintenance therapies, and hopefully we're gonna have maintenance therapies for those that might not benefit from PARP inhibitors.
Okay, thank you. So I also know that you're driving this national initiative called the Ignite Texas study, right? Although it is all nationwide, not just Texas, as I understand. So tell us about this study, and what should our overcomers and their family members know about this particular study, and how may they sign up? What is the current status of it? Everything that you could share. Yeah.
So Ignite TX is designed to help families achieve genetic testing. So what we know from multiple studies is that patients with BRCA or Lynch syndrome, like really share the information with their family members very often. The data would say 80% of the times a patient that is diagnosed with BRCA will tell the family members that they have a BRCA and they are at risk of having the same mutation. So that communication does happen. What it doesn't happen is once the family member gets that information, very, very rarely do family members actually get tested. So some studies like say that as low as 20% of the family members get tested. So that is very, 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 very low. So what we're trying to do with this initiative is try to create an intervention that helps family members really understand why it's important to get genetic testing. And if you turn out to be positive, what does that mean for you? And what strategies are available for you if you turn out to be positive? So there are multiple reasons why family members might not want to be tested. Some family members might be afraid of being positive, right? Because if I'm positive, what's going to happen to my insurance? Like, what are my options? I'd rather not know that I might develop cancer, because there might not be effective strategies for me to try to prevent the cancer. So there are a lot of things that family members might not be aware, and that's why they don't get tested. Some families, that they might think that the genetic testing is very expensive, but now the genetic testing for some family members, different programs might be free. It is covered by insurance, or if they don't have insurance, or do not qualify for any of the programs, it costs around $100 to have the genetic testing. They might not know how to ask their primary care physician how to order genetic testing. So there are multiple barriers that family members face in order to get that genetic testing. So what we're doing with this study is try to overcome those barriers so family members can get tested. So we highlighted this intervention. It's a very simple intervention in which some family members get access to a website where they can watch educational videos, but we also have what we call a genetic patient navigator that helps family members find resources so they can get the proper genetic testing. So that Ignite TX, we launched it, I believe, last December. And the goal was to enroll 60 probants with BRCA-Lynch syndrome. And we were able to enroll all the 60 probants in less than 6 months. So I think we were successful in enrollment. We're still trying to figure out whether the intervention, how effective is this intervention. And so yeah, I think it's, I think to me, that I see patients with ovarian cancer, we know that it's much better to prevent it than once patients develop ovarian cancer, try to treat it. Because the reality is that although there might be more screening in the future for ovarian cancer, so far screening it's far from perfect. So it's much better to try to prevent ovarian cancer than to screen for it. So if you can identify that population at risk, and patients with BRCA are the prime example, right? I mean, they have up to 40%, patients with BRCA1 have up to 40% risk of having ovarian cancer. So that's a population that we can really impact, because we can prevent ovarian cancer in that population. BRCA2, 20%. So that is a population that we can really impact in preventing ovarian cancer. So the really goal is how to convince family members to get the testing.
One of the things that I will mention as I was listening to you, I was thinking that, sometimes it even starts a step above that, because we have, like, several of our overcomers share with us that they have not been talked to about genetic testing by their provider. So this is the patient herself, right?
Yep.
So if the patient herself has not been counseled on getting genetic testing done, then the cascade effect is not going to happen regardless. Yep. So I am almost like, suggesting / thinking that for the Ignite TX study, probably having even some of those overcomers as the first tier, just to kind of, generate that urgency for them to be able to also get their genetic testing. That message is not out there full force. And it saddens me to see that, because we know that the protocol is 100% of ovarian cancer patients should get genetic testing, yet the percentage is below 35 at this point in time. And like, so many people that we talk to tell us that they were not counseled on genetic testing. So
100%. I think that is such an important point. So for anyone listening that has ovarian cancer, or a family member or a friend with ovarian cancer that has not undergone genetic testing, the most important thing that you should do right now is to call your oncologist and make sure that you get tested, because
Right.
it has significant implications about therapies for you and significant implications for your family. And you're absolutely right. I think I would say that we are better now doing testing, but it's not 100%, and it should be 100%. There's no reason why in the United States, not every patient with ovarian cancer should, at this point, should have had received genetic testing. There's no reason why.
Exactly. And there is also no reason why that, when someone is just diagnosed with ovarian cancer, that person and the family is completely overwhelmed, right? I mean, because it's a
100%.
changing diagnosis. And so even though we are empowering our community and asking them to go, seek genetic testing, it really should come from the providers, in the sense that, that should be one of the most important recommendations coming out of any provider at the point of diagnosis, that you need to get genetic testing done. So thank you
Yeah,
for amplifying that for us. It's important.
very,
Uh,
very important.
yeah. So while we are on this topic, I also know that in certain situations and in certain types of ovarian cancer, right? The providers do not recommend genetic testing, or they say it's okay if you do not do genetic testing for your type of cancer. So is there such a thing? And what are your thoughts on those particular subtypes?
So I would say that right now the recommendation is that for all epithelial ovarian cancers, the recommendation is for genetic testing. The rates of BRCA are not as high in other histologies. Like if you look at low grades, it's definitely not as high as a high grade.
Yeah.
The rates of BRCA mutations in low grades is actually fairly low, but it still is recommended to do the genetic testing. The same thing happens with carcinosarcomas, like these unusual histologies. BRCA might not be as high, but it's still recommended. There are other families of ovarian cancer. So we talk about epithelial, but there's other families like germ cell tumors that are more frequent in younger patients. That is completely different family of ovarian cancers. Those usually respond well to chemotherapy, usually happen in younger patients. We do not recommend genetic testing
Yeah.
or BRCA in those patients, just because it just doesn't. It should not be, like, the rates of BRCA should not be very high in that population. But everyone with epithelial ovarian cancer, I would say, I think right now the recommendation is to do genetic testing.
And so I feel, thank you for breaking that down for us. But oftentimes, the patients don't even know what kind of ovarian cancer or what type of ovarian cancer they have. So I think that generic rule of 100% of women should get genetic testing is a good one, because even though you do not need that information for your particular subtype of ovarian cancer, it's always good to have information down the road. So because you never know what therapies are going to be developed in the next 6 months or to a year, when this information may become handy uh, for your
Yeah,
treatment, right? So
yeah. And I work in an institution in which we do a lot of testing for patients, so it's. But yeah, I mean, you're absolutely right. I mean, I think I would say always ask about genetic testing. The worst thing that can happen is your oncologist might say, okay, you have a cancer that usually we don't do genetic testing, and that's fine, but just ask.
yeah, exactly. Thank you. So switching gears a little bit, because you're also a surgeon, what are you most excited about when it comes to the recent surgical advances that are happening in ovarian cancer?
So two things come to mind. So in terms of surgery for ovarian cancer, I think there traditionally, we have always talked about a big surgery called the bulking surgery, in which we do an open surgery and remove all the cancer out. And that was, that was like the standard approach for many, many years. I would say 15 years ago, there was a first trial that showed that giving chemotherapy first to shrink the tumor had the same outcome as patients having primary surgery. So what we call primary debulking versus neoadjuvant chemotherapy had been a very controversial topic in our field, and that study was the first one to show that very similar outcomes, whether you do neoadjuvant chemotherapy or primary debulking surgery. After that study, there have been three more randomized trials. So these are very high quality in general, with a large number of patients that have demonstrated very consistently that giving chemotherapy first is similar to doing upfront surgery. So you can see how the rates of giving neoadjuvant chemotherapy have increased dramatically in the United States. So I think the last time we look at the data, around 50% of the women with advanced stage epithelial ovarian cancer are getting neoadjuvant chemotherapy. And I think that's a fair number. I don't think everyone should get neoadjuvant chemotherapy, but I also don't think that everyone should have primary surgery. I think there is a sweet spot in the sense of what is the right procedure. And the way we think about it is that if we think that we can remove all the cancer out with a primary surgery, and there are different ways of how to look at it, like either with imaging, the CA-125. At our institution, we do a diagnostic laparoscopy. So we put a camera inside and we have a special score that we follow. But there are, depending on the institution, they might have different protocols. But regardless of that, what it's important is that it seems so far that giving chemotherapy first, it's similar to doing surgery first. There's a study that it's probably, the results should be coming out fairly soon. It's called the TRUST trial. And in that study, they're looking at the same question about primary surgery versus neoadjuvant chemotherapy, but this is in centers that have a high volume and they're very high, with surgeons that see a lot of patients with ovarian cancer. So I think this study really, if it shows that similar outcomes, I think we're all going to feel that neoadjuvant chemotherapy for sure is the same as primary surgery. So those results were going to come out. But that's one thing that I do think that if you look at the data and the quality of the studies, that neoadjuvant chemotherapy seems to be, at least until now, similar to primary surgery. And I think we've published a lot of studies looking at that question, and I think all of that has been very, very consistent. But it's an important discussion to have with your GYN oncologist if you're diagnosed with ovarian cancer. And that's a conversation that we always have with patients that present with an initial diagnosis. And the reality is that there are some institutions in which they do more primary surgery. There are institutions that do more neoadjuvant chemotherapy, and there are slightly different philosophies. But again, I think until now, we have the data that suggests that both approaches are similar in outcomes. So the second part to that is that if you can give neoadjuvant chemotherapy and you shrink the tumor, the surgery usually is not as, might not be as complex because you don't have to remove as much organs. You can, the surgery has less complications. Patients tend to recover faster. That's been, well documented in all these studies. The other part to this, and what I'm very much involved, is that for those patients that have a very good response to chemotherapy, to the neoadjuvant chemotherapy, so some patients might have very profound response after 3 or 4 cycles, that we can shrink a lot of the cancer, even almost all the cancer disappears. In those patients, we think that we can offer them minimal invasive surgery. And minimal invasive surgery is either laparoscopy or robotic surgery. So that means that we can do the whole surgery through small incisions. And as long as we can remove all the cancer, we feel that it's the same as doing an open surgery. And patients, if we can do laparoscopy, usually go home the same day, or they just spend one night in the hospital. Recovery is much faster. They don't have a big incision. They have less adhesions. Most of the times they can restart chemotherapy much sooner. So right now we are doing a large study. It's called the LANCE trial, in which we are comparing minimal invasive surgery for these patients that have a very good response to neoadjuvant chemotherapy, and then comparing that to open surgery to see whether it's safe to offer minimal invasive surgery to patients. The reason why this study is important is because when you look at the data in the United States, among patients that receive neoadjuvant chemotherapy, so these are patients that already are receiving neoadjuvant chemotherapy, almost 30% of the patients in the United States that receive neoadjuvant chemotherapy are already having their surgery through a minimal invasive approach. So clinicians have already adopted these technologies, but we don't have very good data to suggest to whether it's safe or not. We think it's safe, But we do not have what we call level 1 information to really confirm that it's safe. So that's why we're doing this study. And what it's important for patients to understand is that this procedure is not for everyone with ovarian cancer. It's only for patients that receive chemotherapy first, 3 or 4 cycles, and that have a very good response to chemotherapy. And that is like around 20% of the patients that receive neoadjuvant chemotherapy. So the vast majority of the patients will require an open incision. It's just a small percentage of patients that have such a good response to chemotherapy that might be candidates for this approach, that minimal invasive approach. So there's nothing wrong about doing an open surgery. I like doing open surgery. I like doing laparoscopy. But, there are some patients that, because they have such a good response, might be good candidates for laparoscopy or for robotic surgery. And that's what we want to make sure that it's a safe approach for them.
That's fascinating. So when is this Lance trial reading out?
So it's a very good question. The trial, we want to enroll 580 patients. Yesterday, I think when we've enrolled almost 200 patients. So I think we're 198, and we're opening the study's open in the United States, and it's open in some sites in Europe and some sites in South America. And I think we're opening now in Korea in the next couple of months, hopefully. So I think we, for the first 100 patients took a while. It was the first phase of the study, but the last 100 patients have been actually very fast. So I'm hoping that enrollment, if everything goes according to plan, we'll finish enrollment in 3 years.
Okay.
This takes time because, again, this is not every patient with ovarian cancer. It's just a subset that receives neoadjuvant chemotherapy that has a very good response to chemotherapy. So it's a small population.
Makes sense. So a curious question I had on the super response rate that you were talking about. So would these be patients who are diagnosed in like earlier stages, or it does not matter? What have you typically seen in terms of chemo, like having a super response to chemo?
So it's a very good question, something that we are very much interested. So I don't think it really matters. I mean, I'm sure it matters the burden of disease. So if there's a lot of cancer, you're less likely to have these profound responses. But one of the things that we've seen is that usually patients with BRCA mutations respond better with chemotherapy, and we knew that there was data before. So we see a lot of patients that have BRCA that have this profound response to platinum-based chemotherapy. Other than that, like how quick the drop in the CM125 is, gives you a good indication. It's not perfect, but gives you a good indication that someone is responding very profoundly to chemotherapy. Keep in mind that only 5% of the patients have what we call complete pathological response. That means that you give them 3 or 4 cycles of chemotherapy, and when you do the surgery, there's pretty much no cancer. So that only happens 5% of the time. So it's not a common outcome, but 20 to 25% of the patients have very, very good responses to chemotherapy that you can potentially do minimal invasive surgery because they have so much small volume of disease in the abdomen.
That makes sense. Thank you so much. And there are so many other questions that are coming to my mind as you're speaking about this. I mean, this response rate could also mean that, they are, could this mean that they're more platinum sensitive versus platinum resistant? The type of cancer, the stage of diagnosis, and maybe perhaps even the age of the patient, and not just the age, but the overall health and well-being of the patient, how fit and how, all of that probably comes into the picture.
Yeah.
So,
and I think for patients that have more comorbidities or are a little bit older, doing this procedure through minimal invasive approach, it's better, right? Because recovery is faster and so forth. So I think there are certain patients that might benefit more for minimal invasive surgery than having to have an open surgery, for sure.
That makes sense. Thank you. So in honor of Ovarian Cancer Awareness Month, I mean, I have just a list of questions that I think that you would be able to help us guide through. So essentially, we know that the PAP test that doesn't detect ovarian cancer, right? So now, should CA125 become standard screening test at well women exams? Why and why not?
So it's a fascinating question, and people have looked at that particular question in large studies. And when I say large studies, like thousands and thousands of women try to screen for ovarian cancer. So far, screening for ovarian cancer in the general population has not been very effective. And there are different strategies that have been tested, doing an ultrasound, doing a CA-125. There are strategies not only doing a CA-125, but doing CA-125 serially. And if you see an uptrend in the CA-125, then at that point doing imaging. In the larger study done in the UK, these strategies really didn't translate into benefit in the general population. And there are a couple of reasons why this happens. One is that there are other things, especially in premenopausal women, there are many things that can elevate your CA-125, like pretty much anything that inflames the peritoneum, or the inside of the abdomen can raise, the CA-125 can go up. So there are other things that you can cause like these rises in CA-125. In postmenopausal women, there are less things, or there's entities that can have led to increase in CA-125. But the other thing with CA-125 is that it usually doesn't go up in early stage disease. Usually goes up when patients have more stage 2 or stage 3 or stage 4. So in order to have a right screening method, what you want is to detect patients when they have pre-cancer or when they have stage 1 disease. Yeah. Because really detecting patients when they already have stage 2 and above ovarian cancer, it's not as effective. So CA-125, that's one thing. Like other things can cause rise in CA-125. And also it doesn't really, it's hard to detect patients when they have stage 1 disease based on CA-125. The other thing about screening is that, particularly for ovarian cancer, that it's not a very common overall disease. You have to have a test that it's what we call very sensitive and very specific. And that is just how good a test is detecting ovarian cancer, or saying, look, you have a high risk of ovarian cancer, or saying you have a low risk of having ovarian cancer. And the reason why you have to have these, what we call, again, high sensitivity and high specificity, is because if you are, presumably based on whatever test you're using, at high risk of ovarian cancer, that means that you have to take that patient to surgery and remove the fallopian tubes and the ovaries, right? So that's a surgery. So you don't want to do a lot of unnecessary surgeries. And usually for patients, like in the prevention world, what people usually say is like, we want to have like 10%. So your threshold should be doing kind of like 10 surgeries and at least finding one patient with stage 1 or ovarian cancer, because we don't know what is the precursor yet for most ovarian cancers. There are something called STIC. There are other entities, but again, we don't really know. It's not like cervical cancer that there's like a nice progression that takes 10 years. In ovarian cancer, we don't see that kind of like, we have not been able to identify that kind of like those steps yet. In the future, I think we will, but right now we have very limited understanding on what is the usual progression from normal ovarian tissue into full-blown ovarian cancer. So just going back to that point is that you have to have a test that at least if you do 10 surgeries, one of them, that you are preventing an ovarian cancer, and CA-125 it's not there yet. Even combining CA-125 with ultrasound. So unfortunately, right now, for the general population, it's not recommended, because we still haven't had good data about it. I think eventually we're gonna have screening ways to do it, but right now we don't.
Okay. So the next question is that, if we have family history of ovarian cancer, we talked about it at length. So regardless of BRCA status, right? We have family history of ovarian cancer. In that situation, does our risk increase, and why?
Yeah. So yeah, the risk. So if you have family member with ovarian cancer, and you've done the genetic testing,
Yeah.
and it's negative, um, then yes, the risk is still higher than the general population. There was a study years ago in which showed that the risk was slightly, was like around 3%. It was a modeling study, so I don't know how good of the data it is, but yes, to the point that there were some experts that might recommend that if you have a first-degree family member with ovarian cancer, that you would at least consider having a prophylactic bilateral salpingo oophorectomy. I would not say that that is a strong recommendation. I think data to for the data the data to suggest that recommendation is very limited, but it's a conversation to have with your provider. At least I think if you have two family members with ovarian cancer, that would make me a little more worried. But again, I think it's a conversation to have. I don't think every family member should have these prophylactic surgeries, but at least having a conversation with your provider about it. Keep in mind that genetic testing has evolved through the years. So if you had genetic testing done 10 years ago, you should probably repeat the testing now because we have identified more variants now.
Mhm.
So just keep that in mind. So if it's been a while since you got the genetic testing and you have ovarian cancer, your family member had ovarian cancer, you did genetic testing, 5-7 years ago, you should probably repeat the genetic testing.
So what I heard you say is that first of all, the first recommendation is if there's family history, we talked about this at length that we should get genetic testing done.
Yep.
So now if the genetic testing is negative, at that point, have a conversation with the physician about what your options may be.
Yep.
Even though you do not carry the mutation, you still have a higher risk of ovarian cancer versus a general population, right? And then you said that folks who have the mutation, obviously they're at an elevated risk. For those patients that carry the mutation, then would you consider or would you recommend the preventative hysterectomy?
A preventive hysterectomy. So if someone has a BRCA mutation,
Yes.
So definitely recommendation is removal of the fallopian tubes and the ovaries.
Okay.
That is after childbearing, after patients, if a patient is after 35 years old and they have done with childbearing, and that's when we recommend prophylactic bilateral salpingo but remove the ovaries and the fallopian tubes. Keep in mind that the risk of ovarian cancer in BRCA1 patients is earlier than BRCA2. So really the risk in BRCA1, we see the uptick in around 40 years old. In BRCA2, that happens a little bit later. So you may have a provider that sees a patient with BRCA2 and might be willing to wait a little bit longer to do the prophylactic bilateral salpingo oophorectomy. In general, my recommendation is if you're done with childbearing and you're around 40, even if you're BRCA1 or BRCA2, just have the surgery. In terms of the hysterectomy part, that's a very interesting question. And like many things in GYN oncology, there's not a straightforward answer to that. There is some studies that have suggested that patients with BRCA have an increased risk of what we call uterine serous carcinoma. So that's an aggressive type of uterine cancer that on the microscope resembles ovarian cancer. So the studies that have shown that are all retrospective or database and very limited. So I would say that that's a conversation that I have with patients. And I say, what I tell patients is that there's very limited data. Like if you look at the guidelines do not recommend a hysterectomy. But, I talked to them about it and I mentioned, you might be at increased risk of this cancer. It's an unusual type of cancer. The increased risk is probably not that significant. But if you don't want to have any risk whatsoever, I'm happy to do a hysterectomy. The other part about when we talked about hysterectomy is for patients that are premenopausal that, that have BRCA, and they might have history of breast cancer. There might be some reason why we also want to remove the uterus because they might have, the recommendation might be to take tamoxifen or other therapies. So there are other reasons on why, your provider might recommend a hysterectomy if you have BRCA. But one of the things that we talked about is that risk of the high grade uterine serous carcinoma.
Thank you. So we talked a lot about the family history part. So and you also said that if we have risk factors for ovarian cancer, whether or not I should have a preventative surgery depends on my unique situation, and conversation with the physician is warranted in that case. So there is no like hard and fast that this is the protocol kind of a thing, because it just depends on where you are in your life and what your options are, and what kind of family history that you have. So, and then I know that this is a favorite topic and we are kind of getting to the top of the hour also, but just very briefly, women getting pregnant and having children, right, after ovarian cancer treatment. Tell us the possibilities and what do you see?
Yeah, so fertility preservation, this especially for young women that have ovarian cancer, fertility preservation, it's an option for patients that have stage 1 ovarian cancer. So that means that the cancer is localized to the ovaries. There is a lot of debate about whether the histology or the grade should come into play. So it should only be for those that are truly stage 1, localized to the ovaries with low grade ovarian cancer, because the risk of recurrence is much lower for those that are low grade. And for certain histologies like clear cell, the risk might be higher. So there's a lot of nuances about that. But I would say that there's certainly some patients that are good candidates, that are young, that it might be feasible to do fertility sparing. And that means that we just remove the ovary and we do staging procedures, making sure that we take out the lymph nodes in the pelvis and next to the aorta to make sure the cancer hasn't spread, taking biopsies of different areas again to make sure that the cancer hasn't spread outside. So for those patients that are truly, truly stage 1, yes, there's an opportunity for fertility preservation. We have done studies in which we have compared patients that underwent fertility preservation for stage 1 ovarian cancer and compared to those that had complete staging, and we see similar outcomes. All of the data is what we call retrospective, so looking back with a lot of limitations. But it seems that, again, for a very well-selected population, that is definitely an option. I would say keep in mind that stage 1 disease is not very frequent, and also ovarian cancer is not that frequent also in young women. So these are very unique, situations. But yeah, I mean, it's definitely a possibility.
Thank you. So we covered a lot of topics today in honor of Ovarian Cancer Awareness Month. Is there anything that I've missed asking you that you would like to share with our overcomers? Any burning topic? Okay.
Yeah, I mean, I would say that the field is changing very rapidly.
Yeah.
I think there's a lot of new therapies coming out. So I think it's great that patients being informed. I think, to me, the most important thing that we talked today is the genetic testing. If you have not had genetic testing, either you had ovarian cancer or have a family member with BRCA or Lynch syndrome, make sure that you have genetic testing, because we can prevent cancer in patients and family members. So very, very, very important.
Thank you. And so in honor of our Awareness Month, what message of overcoming would you like to share with everyone listening today?
Well, first of all, just thank you so much for the opportunity to be here. And I think for me, it's always been an honor to take care of patients with ovarian cancer. I think it's just an honor to be involved in patient care, and being involved through all the trajectory. And it's amazing to see the courage that patients face through all of this therapy. And for us that are involved in research, it helps us stimulate us to try to come up with better strategies that we can offer our patients. So makes us work harder, and it's again, it's an honor to be involved in their care.
Thank you so very much, Dr. Rauh-Hain. This was a very meaningful, impactful, and insightful conversation that we have had with you today, especially with many call to actions in observance of Ovarian Cancer Awareness Month. So thank you for your time today. And overcomers, hi, we have a guest. Hello.
Sorry about that.
No, it's great to see. It's great to see our future. Looking bright and shiny. So and overcomers, hope that guest appearance made the day for you. It did for me, for sure. We'll be back with the next episode of Connect Over Coffee very soon. Until then, you keep overcoming. Thank you and bye.